Hello and welcome to the talk on plantar plate pathology. One thing you will notice is that there is a lot of overlap between the first two lectures that I gave. Oftentimes, you're treating several different pathologies with toes. It's very rare where you are fixing just one thing. Objectives for this talk: understanding relevant anatomy to the plantar plate, understanding different diagnostic imaging modalities, as well as understanding surgical options and different treatments. So what exactly is the plantar plate? The plantar plate is a fibrocartilaginous structure that sits directly underneath the metatarsophalangeal joint. The deep transverse metatarsal ligament will pass through this structure, and the plantar plate is a direct extension to the deep fibers of the plantar fascial ligament. Oftentimes, when you have a tear of the plantar plate, you'll notice it at the base of the proximal phalanx. More often than none, the second metatarsophalangeal joint is commonly affected with plantar plate tears. Your female population has a higher incidence of tears than the male population. With the athletic population, average age range is between 20 to 30 years. In your more normal or sedentary population, average age is 50. And the patient may or may not recall an injury, especially those that are in the sedentary life. They may recall stubbing a toe several years ago, and over time the toe started to drift. Your first ray may be the problem, and with first ray insufficiency, there may be transfer lesions at the lesser MPJs, specifically metatarsophalangeal joints 2 and 3. And so there may not be an actual tear of the ligament, but with transfer lesions, there's consistent stress that's placed on the plantar plate, and over time, you get attenuation of the ligament, and over time, we'll get drifting of the toe. So, I think what's really important with your HBI specifically is asking them if they can recall an actual traumatic event, if they recall stubbing their toe, how long has this been going on for? Have they noticed deformity getting worse with time? These are all questions that you need to ask. This will help dictate what you do for the patient. Try and gauge if this is more of an acute situation that happened recently, or is this chronic and has been longstanding for years. With your physical examination, dermatologically, you oftentimes will notice painful callus lesions under the lesser MPJs, um, commonly seen with your first ray insufficiency. And again, I'm going to sound like a broken record, but first ray insufficiency is a big problem with these types of things that we deal with. With the musculoskeletal examination, you're looking to see, is there any deformity? Do you see any crossover of the toes? If there is a deformity, now is it rigid in nature or is it flexible in nature? Having the patient stand, performing a clicking and push-up test. Are you able to perform a Lockman's examination? Is there a positive Lockman's? Are you able to essentially displace the toe? One thing that you may realize is that you could still have a positive Lockman's examination even if the plantar plate itself isn't torn. Over time, it becomes attenuated and loose, and it's not as strong as it used to be. I almost think about this sort of like lateral ankle instability for our patients. You can have a positive anterior dorsine even if the ATFL ligament isn't necessarily torn or ruptured. Over time, with chronic lateral ankle instability, the ligament itself becomes attenuated and weak and is no longer functioning properly. And so these patients will often trip. I almost look at this kind of like that for plantar plate. If the plantar plate is insufficient, it's attenuated due to first ray insufficiency. Well, now the plantar plate is not doing its job anymore. The toe is now drifting, and so forth. And so you need to address that. Literally just talked about first ray insufficiency here. And again, I'm going to sound like a broken record, but it's something you need to address as it's probably your primary problem or can be your primary problem. rule out neuromas, and then equinus. Diagnostic imaging, you always want to start with reviews of the foot to assess for any deviation of the toes, assess the metatarsophalangeal joint for any arthritis, and is there a hallux valgus component. You can order an MRI, and you need to be aware that there can be a false negative. And the reason for this is more often than not, MRIs are giving you 3 mm slices, and this is too big for the plantar plate. The plantar plate is a very small structure, and you should order 1 mm slices to better appreciate the plantar plate. Now, you may not appreciate a tear on the MRI, but there may be thickening of the plantar plate. Normal thickness is usually between 2 to 3 mm, and a pathologic attenuated ligament is roughly 4 mm or greater. And this is typically appreciated best on a frontal view. Some may consider taping the toe in a stressed dorsiflexed position, and this allows the tear to be seen better. As if the foot's in a relaxed position, uh, it may hide the tear, and so with flexing the toe, you are accentuating the deformity or tear rather. Diagnostic ultrasound can be extremely helpful. It's dynamic in nature, so you're able to see the tear in real time. As most of you know, though, diagnostic ultrasound is very user dependent and can be difficult to perform. Diagnostic arthrography is an option. This is used with dye, and if dye is seeped out of the joint, this is indicative of capsule or plantar plate tear. Unfortunately, I have no experience with this, but it is an option. From a conservative standpoint, you may consider taping and strapping the toe in a plantar flex position to alleviate the plantar plate and offload it, and then consider placing the patient in a post-operative shoe or a cam boot for some time. I encourage my patients to ice and elevate at home. Once they start to feel better, I will then transition them to more of a stiff-soled shoe. For the active population, activity modification is important. A lot of these patients are looking to get right back into their activities, and these are talks you must have with the patient and set realistic expectations. I do discuss with patients who are being treated conservatively that we might be able to get you feel better, uh, but you need to be aware that over time the toe might try to drift and cock up, and this is because the ligament is not as strong as it used to be. And so you have to set these expectations for these patients. So let's talk about a few approaches here and surgical repair options. So this is looking at the plantar approach, and this is a direct approach. And I know most of us are not used to this type of dissection, and it's not very tough though. Essentially, just making an incision directly underneath the metatarsophalangeal joint, uh, and then you're just going through the subcu layer, and the subcu layer is extremely thick in this aspect of the foot. Once you get through the fat pad, though, you will come across the flexor complex. You're going to want to protract that out of the way, and then long behold is your plantar plate. And there's a few different repair options at this point. Some people like to use suture anchors, and you can place the suture anchor directly into the phalanx, base of the phalanx, and then uh, capture the plantar plate with that and tie it down. You can use sutures through the actual plate and then create drill holes through the phalanx and tie the sutures dorsally. And then you can also just do more of a pants over vest type of technique and shorten the ligament and retension it. The problem with this approach is if you are dealing with chronic tear, there may not be much of the ligament left for you to repair. So something to take into consideration. I do like this technique for more of your acute patients, but for some of the longer standing deformities, uh, just be aware that there can be a problem with having no suture. I'm sorry, no ligament really to repair. Um, that's something to take into consideration. Uh, Most of us are probably used to the more dorsal approach, and several different companies out there create some devices to try to distract the joint out. In some cases, you may need to make a osteotomy to get better access to the joint and the plantar plate. There's various suture passers that you can use to grab the ligament and uh, and then create several drill holes through the phalanx and reroute the sutures through the drill holes and tie the suture. Um, both ways can be difficult. The dorsal approach can be difficult because you're working in a very small space. If you do the plantar approach, you're then having to deal with potentially a painful scar. Um, so depending on what you feel comfortable with, there's no right or wrong way to do this. And again, not to sound like a broken record, but the flexor tendon transfer is more of an indirect way to fix this. This is something that we talked about in some of the previous lectures. But if you have a long-standing deformity, 2, 3 years out, more than likely there's no ligament left, or it's frayed or completely attenuated. And so, a great way to offload that ligament is to just perform a flexor tendon transfer. Um, this way, you don't have to try and repair a ligament that may not be there anymore. More often than not, you're having to fix a hammer toe, and maybe you are doing a metatarsal osteotomy on top of that. But this is a great way to really dial in that correction and splint the toe down. For more of my acute patients, we will splint the toe in a more plantar flexed position, and they'll be placed in a cam boot or a post-operative shoe, and they'll be left partial weight bearing. I do continue to splint these patients in that plantar flex position for almost 4 to 6 weeks post-operative, maybe even longer, depending on how they're doing. And I'm a big believer in physical therapy, and not just for this, but really all my procedures. I do find physical therapy to be a great adjunct to really help with swelling, edema, pain, and uh, some of the scar tissue that may form. And I do have these patients perform mobility exercises at home for me to try and lessen any scar contractures. I do find that using physical therapy uh, may be better just because sometimes patients are too afraid to try and mobilize their own toe. So I rely on the therapist for that. So looking at some of the literature, um, this paper published in Foot and Ankle International in 2013 was looking at instability of disruption of the plantar plate and instability of the MPJ. And the study found that when adding a flexor tendon transfer to any sort of plantar plate pathology, there is significant amount of stability to the joint. And so I encourage you to consider adding this procedure to your MPJ pathology. I do find it to be very beneficial, and it really does help to correct a lot of the deformities that you may be suffering with. This is a paper that Chris Heyer and Mark Preisel wrote in JFAS 2017. It's an outcome paper, and they assessed 144 toes. And what they found was out of the 144 toes, 87% had great perfect alignment. They were rectus. 7.6% had reoccurrence, and 2.8% needed a revision. So you look at that and you say to yourself, that's not terrible. And just to be clear, this is a plantar approach that they used. They also did a survey to all their patients, and unfortunately, only 53% of these patients responded back. So it's roughly 76 toes, and it was a very mixed review. Of the 76, they stated that 27% of the toes did not purchase the ground, 31% were left with a painful scar, and 43% would not undergo this procedure again. So a very mixed review on this approach. So again, like I mentioned, I don't think there's a right or wrong way to do this. If you are attempting a plantar approach, there are some incision techniques that you can perform. You can do more of a lazy S incision to try and avoid the weight bearing surface. That way, you don't go directly over the MPJ and more so in the inner space, and that can alleviate some of the scar formation, painful scar formation that may be that the patient may experience. But you know, plantar plate insufficiency pathology is not an easy thing to address surgically, and so whatever you feel comfortable with, and, is the way I'd go with this. Need to thank my fellowship attendings for allowing me to use some of the X-rays and pictures from fellowship. Thank you.